Hello and welcome to our first official lecture in RS3060 related to the presentation of stroke. Now there are many different regions of the human body that we wish to cover in this course, and it makes sense that we're going to start actually in a particular pathological presentation that involves the brain. From there we can build up to various different sections in the human body, but starting in this region gives us a chance to understand some of the important, relevant concepts in terms of what a stroke is as a presentation and how it can influence the central nervous system. And from there we can build up into different areas and lectures going down the road. Now I'm providing an outline of what it is that we want to cover in today's lecture related to stroke. We want to define what a stroke is and discuss its epidemiology. We want to appreciate the various presentations and basic pathology. One presentation of a stroke is not necessarily going to be the same as another presentation or a third. There will be different regions of the brain that can be affected. There will be different levels of involvement, and all these feed in to how it clinically presents. And we can relate that back to a bit of a basic sense of what pathologically took place. And we want to review the consequences for patients by discussing the selected impairments that are there. There are motor, verbal, and visual effects that we're going to discuss in this lecture secondary to a stroke that has occurred. So what is a stroke? Well, by definition, it is a clinical syndrome characterized by the sudden development of a persisting focal neurologic deficit that persists for at least 24 hours and is due to an abnormality of the cerebral circulation. That's a mouthful. It would be easier if we could break that down just a little bit. So first off, a clinical syndrome. The syndrome in itself, a syndrome is a constellation of impairments. So there might be signs or symptoms brought together that gives us a picture that a stroke has occurred. It's not just one thing. And these are characterized by a sudden development of a persisting focal neurologic deficit. Now, focal would be where we have a center or a main point of interest, and we can relate some of these sudden neurologic deficits that are presenting due to an isolated part of the brain that is compromised. Different parts of the brain will have different clinical syndromes or presentations, and we can map out where the stroke has occurred based on that. And in terms of what it's due to, it is due to an abnormality of cerebral circulation. And this is the anatomic importance because it highlights that a presentation of a stroke is due to alteration of blood flow. Now that may be because there is a blockage and something is preventing blood flow from getting there, or the blood flow to the site itself is compromised as it hemorrhages outward. Now in going into the epidemiology related to stroke, there are an estimated 62,000 strokes and TIAs that are admitted to emergency departments in Canada each year. That's arguably a timeline of 1 every 9 minutes. Now, notice how we highlighted here the term stroke, and here's the term TIAs. We're going to come to that term and clarify the difference a little bit later. In looking at stroke, stroke is the third leading cause of death in Canada. Each year, over 13,000 Canadians die from stroke. So its impact is significant. Further to that, in terms of the clinical impact, stroke is the leading cause of serious long-term disability, with stroke survivors representing the largest group admitted to neurologic rehabilitation hospital settings. So, for a better concept of that, we have usually an acute and a neurologic setting that is based more towards rehab. In the acute setting for a neurologic presentation, if an individual is admitted who has suffered a stroke, the main aspect is to try to medically manage them well, to prevent death, to ensure that they are medically stable, and to, through that, address some of their medical concerns and functional restrictions. After that, you're looking to transfer them to a rehabilitation aspect of, for example, a hospital setting. And that's where they're more directly going to be involved in performing tasks within a team of health professionals that can include a physiatrist, pharmacist, physiotherapist, occupational therapist, speech language pathologist that will be involved in various aspects of their care. And their main focus at that time is progression of movement, strength, function, and social interaction. In terms of epidemiology, stroke is actually more likely to occur in men than in women. And as one might expect, stroke does increase in terms of risk with age. So bringing up epidemiology a little bit more, we appreciate that stroke has a significant influence on the need towards healthcare, the representation in a neurologic rehabilitation setting. But let's go over some of the risk factors related to it. Blank in 10. We're going to come back to that in 1 second. Canadians have at least one risk factor for health, disease, and stroke. So there's certain risk factors that are present. These factors include eating less than 5 servings of vegetables and fruits a day. They also include smoking, physical inactivity, overweight or obesity, high blood pressure, diabetes, and stress. So keeping that in mind, if you had 10 Canadians in front of you, how many of them would you suspect have at least one risk factor that we've outlined for the presentation of heart disease and stroke? And these two clinical conditions can be affiliated. Give it a thought for a moment. How many in 10? 3, 2, 1. It's actually 9 in 10. So arguably, a significant majority of the population have at least one risk factor for the development of stroke. Now that we have a better sense in terms of the epidemiology related to stroke, let's step back into an appreciation of the anatomy. Here we have the human brain, and we want to appreciate that blood flow and the dependence on oxygen is significant related to this anatomic structure. The brain appreciates a constant rate of total blood flow, and there's a reason for that. It has a high dependence on oxygen, and the main way that we get oxygen to the brain is via blood flow. So having a constant rate of that is going to ensure that we're able to keep all process of the brain functioning well. If we're looking at that constant rate, we're looking at a reliance of autoregulatory mechanisms that counteract fluctuations in systolic blood pressure. In translation, the body knows that blood flow is very important, and it will do what it can in certain situations to try to deal with certain fluctuations in blood pressure that may adversely affect the delivery of blood flow and thereby oxygen. And because the brain is highly intolerant of oxygen deprivation, even within seconds, there can be affiliated loss of consciousness. If you've ever gotten out of a seat too quickly and then had a head rush and felt unsteady, then that would be an example of it. Anoxia, or the deprivation of oxygen. So anoxia means no oxygen there at all. For 4 or 5 minutes can lead to irreversible damage. Now that we have a bit of an appreciation of how much the brain relies on consistency of blood flow and thereby consistency of oxygen delivered to the tissues, let's also appreciate some of the major feeder arteries that are involved. And these feeder arteries, deemed that because they do feed important blood flow to the brain, have various pathways that go up. If we follow some of this arterial pathway, we can appreciate there on the left we have our right subclavian artery, and it will then travel further superiorly into the right vertebral artery. And if you're following it, you'll notice that it does go through your cervical spine and each one of these bit of bony shells that protect it there and guide it up and along the root of our spine. At its endpoint, it will eventually come to the basilar artery. So this is one of the pathways that is supplying the brain. Another one can be found not as posterior, but more anterior. Here in the front of the spine, you'll see the right common carotid artery, which will eventually split into the internal here and external here carotid arteries. And if we follow the pathway up, they'll continue on here into the brain with various branches and supplying more direct. We're going to see that a bit more in the next slide. One of the take-homes related to these pathways is that there actually are two of them. And that way the body is trying to do what it can on supplying appropriate blood flow through two different means. In which case, if one is compromised slightly, then relevant blood flow will still occur to the brain. Now, if one of these is compromised significantly, it may be a different situation, and that's where a pathological presentation could be found. But you have more than one arterial supply via the pathway leading up to the brain itself. In this slide here, we're looking at the underside of the brain, and there are various anatomical structures that are supplying it. Here we have a vertebral artery, and we talked about that on the previous slide. It progresses further into the basilar. Now these are in the posterior section of the brain. If you follow the basilar a little bit further, you'll eventually come to the posterior cerebral artery. One of the reasons why we're going over the anatomic makeup of these different arterial supplies now that they're going into the brain is because different regions that suffer a stroke from compromise of these arteries will have different clinical presentations because they influence different parts of the brain. So from here, we have our basilar artery leading to the posterior cerebral. If we continue on, we do have a communicating artery that will lead towards this internal carotid. We also have a middle cerebral artery and an anterior cerebral artery. And again, we're giving a lot of anatomic information right now, and we want to have a bit of a sense of the lay of the land, because as we go into different presentations of stroke, we want to appreciate via that some of the anatomic landmarks that are relevant for each. We're going to talk about middle cerebral artery. We're going to talk about the anterior cerebral artery. That's right there. We're going to talk about the posterior presentation of stroke in our next lecture. So again, anatomically knowing the lay of the land will connect this slide to clinical presentations later on in this lecture and the next lecture. So we've talked a bit about the anatomic makeup of the circulatory supply to the brain. And that's going to be relevant because that's actually a way of classifying a presentation of a stroke, like I was talking about in the last slide. But it's not the only way. Etiology is relevant. Strokes can present as either a thrombus or a hemorrhage. And we're going to break that apart a little bit in a few slides. The management of a presentation or a category is also a way of classification. So there are transient ischemic attacks, that would be TIAs, and again, that's coming up later. Minor versus major. So there's different categories in terms of the degree of involvement, as well as going over the specific vascular territory. So the anterior cerebral artery, the middle cerebral artery. It's not uncommon that you use more than one of these to categorize a presentation of a stroke. So the location where it happens, such as the particular vascular territory, the degree or significance of it, so whether it is minor or major, as well as the cause, the etiology, be it a thrombus or hemorrhage. All these are relevant in terms of what presentation we are working with. Let's lead into etiology first. A major risk factor for the development of a stroke would be arteriosclerosis, and that would be the presence or ensuing plaque formation. Now, the plaque is made up of fat or cholesterol, and it builds up in the arterial walls that supply blood flow from the heart to the brain over time. There's certain areas in the pathway that we've presented in the previous slides that are a little bit more likely to have a plaque be formed. Those include areas of angulation, such as right here at C2, which is the second vertebrae just below your skull. There is a bit of a curve or angle, and it's more likely that plaque will be built up there. Where there is a dilation or an opening, although it seems counterintuitive, but if plaque is coming into that zone and it tends to collect into an open zone more often, it still can be in a region where plaque can be found. Contrast that with constrictions. These 2 points can be found here, for example, in the common carotid, where there are sections naturally where it's a bit wider and a bit narrower. And in these dilations and constrictions of the carotid artery, there is a bit more risk. The final area would be the bifurcation down here. This is your subclavian artery. That's where it originates. And where it bifurcates or splits off, it does tend to have a bit more of a risk for plaque to build up there. So where there is an angulation, dilation, constriction, or bifurcation, there's a greater likelihood of plaque formation. And affiliated with that, if it should build up sufficiently, then you're going to lead into an ischemia. Ischemia is where we have an inadequate blood supply to an organ. In this case, it would be an inadequate blood supply to the brain. So where we're appreciating that blood supply to the brain can be compromised. And one reason that it is compromised underneath the realm of ischemia, or something getting in the way and preventing blood flow, such as plaque. Let's go over the relevance of what blood flow and thereby oxygen means to the brain, and what might happen if that's reduced. So in normal neurotransmission, as seen here, the neurotransmitters, such as for example glutamate, are synthesized in the neuron and stored in a presynaptic vesicle. There's going to be a depolarization of the axon as it reaches a presynaptic neuron, and as a result, the action potential causes release of neurotransmitters to go into the synaptic cleft. From there, you're going to have the uptake of the neurotransmitter by the postsynaptic neuron. And this is how things translate into a multitude of different neurologic connections in the brain, ensuring that a signal will be provided from one neuron through to the other via the reliance of neurotransmitters that will cause a myriad of different normal everyday activities to progress as expected. So let's contrast that with a pathological presentation, known as a bit of an ischemic cascade. Here it begins with ischemia. The blood flow to the brain is compromised. And in response to this, with the affiliated ischemia, you're going to actually have an excess release of neurotransmitters into the synaptic cleft. So instead of it being controlled, they're just not going to go full bore into the cleft in a large quantity. The result of this lack of control of release is going to cause a progressive disruption of energy metabolism. Affiliated with that is an influx of calcium ions and a failure of the neuronal membrane pump. So you're getting a whole bunch of neurotransmitters that are coming into the synaptic cleft, and at the same time our way of trying to deal with this excessive collection and work with some channels and pumps that will try to reduce it, it's also compromised. It fails. So we're starting to lead to a formation of substances that cause further damage to brain cells, such as free radicals, nitric oxide, cytokines. You're already going to have, unfortunately, damage from a lack of blood flow and a lack of oxygen to the brain. Also, because there's a lack of blood flow, there is going to be an alteration of neurotransmitter release, an inability to control for the excessive neurotransmitter, and finally, an increased amount of brain damage from the release of adverse substances that can't be well controlled. So far in our talks, we've talked a little bit on the etiology of impaired cerebral circulation in the form of ischemia. It's where we're looking at an ischemic or an occlusion that would be present. And there are a couple of reasons why that might occur. We've talked about how there could be a formation of a blood clot that would be present in the cerebral arteries or branches, and that would be known as cerebral thrombosis. And again, that's where you have this buildup of plaque over time that prevents blood flow from progressing from heart to brain in an appropriate way. There's another reason why that blockage may happen, known as cerebral embolism. And that's where you actually have a blood clot or plaque formed elsewhere and released into the bloodstream. Now, these blood clots could be formed actually in the leg after a total knee replacement or a surgery. They can be found in the arm, sometimes after sports injuries. They can be found within forms of the lungs. There's a myriad of different locations where they can be present. A cerebral embolism is where one of these plaques was dislodged elsewhere, released into the bloodstream, and now becomes formed and acts as a plug in the cerebral circulation. Besides the ischemic presentation, there's another way that an etiology of a stroke can occur. It's known as hemorrhagic. This is where we have an abnormal bleeding that is present. And the reason for that can be where we have in the cerebral structures a rupture of a cerebral vessel. So it's not that we have a plug and it's stopping blood flow, it's that the blood vessel itself actually expands and ruptures. We can also have it where it's not per se the blood flow within the cerebral tissue itself, but it could be in the subarachnoid space. And that usually forms from an aneurysm. So now we've expanded the etiology to include both ischemic as well as a hemorrhagic presentation. If we've got a bit of an idea of what occurs in the ischemic phenomenon, we might as well talk about what will happen in the hemorrhagic presentation. So first off, this is a primary non-traumatic cerebral hemorrhage, which means that it's not affiliated with an external force that you might see in traumatic brain injury. One of the main causes that will be present is the presence, again, of atherosclerosis as well as hypertension. Hypertension would be high blood pressure. Now, not only could atherosclerosis cause a plaque that could occlude blood flow, it could also affect the integrity of the surrounding vasculature and the ability of it to deal with the pressure of blood flow. Same thing with high blood pressure. Over time, that will result in weakened small blood vessels that will be in the presence of the increased blood pressure. From there could be the progression of microaneurysms or arteriolar necrosis that precipitates this bleeding. So it can start small, but as there is further and further progression of these microaneurysms or micro tears within the vessels that are there, more fluid will become confined in the space, increasing intracranial pressure that will be present until finally adjacent brain tissues will be displaced and progress further, producing ischemia. So there could be a small change that happens in the vasculature walls over time, resulting in weakening from the presence of atherosclerosis or high blood pressure. And as more fluid builds, eventually that's going to expand further out and actually go into the adjacent brain tissue, causing a further amount of ischemia or lack of oxygen supply. So let's look at a visual representation just to clarify one more time, hemorrhagic versus an ischemic stroke presentation. We initially started to talk about the ischemic stroke presentation where we have the occlusion of blood supply, and that results in ischemia from a removal of blood supply. So here, the clot would stop blood supply to this particular region of the brain, affecting the brain's ability to perform the tasks that are designated in this particular region. Compare that to this bleed that is present in the hemorrhagic presentation. It will increase intracranial pressure, and the ischemia from the pressure of the bleed will also be there. Now, between the two, these are not even. It's not where we have 50% ischemic and 50% hemorrhagic. If we look at a group of individuals who have suffered a stroke, odds are only 20% will have had a hemorrhagic stroke. That's fortunate because generally a hemorrhagic stroke is more likely to cause a greater degree of damage and neurologic issues. And part of the reason is that the expansion that would be there would damage some of the brain tissue as well as the affiliate ischemia. Another reason is that if an individual is fortunate enough to get to hospital after the signs and symptoms of a stroke, then within the emerge, if appropriate tests are done to isolate that it is a clot, medication can be provided which can then effectively address the clot that's present there, if it's done within time. If it's done within that period of time, the likelihood of neurologic recovery is improved compared to this scenario. Here, there is no clot per se that we can affect with medication. And in fact, we don't want to try to increase blood flow in this region because for hemorrhagic presentation, blood flow is already arguably too much going there. So hemorrhagic tends to be less common, of greater degree of harm, and at least in an ischemic presentation, there is the potential of use of medication in the emergency realm that could limit the amount of neurologic damage incurred. So we've talked about strokes related to the etiology or the presentation. Now there's another way we can try to define the presentation of an individual who has suffered a stroke in the realm of management categories. One of the more straightforward one would be one of a presentation of a major stroke, where an individual is medically stable, but they present with severe impairments. And an understanding of these impairments will come in further slides. An individual who has a deteriorating stroke, unfortunately, is presenting with the deterioration of neurologic status after admission. There's a particular level of involvement post-stroke, and now some of these clinical findings are getting worse over time. There is a such term as a young stroke, where a stroke has occurred in a person younger than 45 years of age. Now, that individual who suffers a stroke at that age actually has the potential for better recovery because of their age. And also, there's a presentation of a transient ischemic attack, and we've talked about that in previous slides, and we're touching on it now. The short form for this would be TIA. So what is a transient ischemic attack? Well, using a case scenario may help to clarify some aspects of it. Case in point, you have a 70-year-old man in a grocery store who noticed his left arm went limp, and that lasted for about 25 minutes. Now it went away and everything was normal. He went to hospital emergency room because he thought he was having a heart attack. It involved his left arm. Now cardiac testing was done and it was found to be normal, and he was sent home. The next day he noticed 2 fingers in his left hand felt numb, lasted about 30-40 minutes, and then went away completely. On the 3rd day after the initial incident, he noticed numbness in the same 2 fingers. He went to emerge again, was admitted, and it got worse in hospital with problems involving his face, his left arm, and speech. And when he attempted to speak, he lisped. He was unable to form words effectively. So in the previous slide, we have an example of a transient ischemic attack. And a transient ischemic attack, also known as a TIA, will involve a focal area of retinal or cerebral ischemia, which means it will involve the eye or the brain. By definition, they do not last longer than 24 hours. And affiliated with that, after the attack is over, there is no evidence of residual brain damage or permanent neurological dysfunction. So in that sense, they are not a stroke, because a stroke will have signs and symptoms that will present for longer than 24 hours, and they have a significant higher likelihood of there being the presence of permanent neurological dysfunction or residual brain damage. Now, that's not to say that we should ignore the presence of a TIA. The reason for that is that it is a precursor to the susceptibility for both a cerebral infarction or a stroke to occur, as well as a myocardial infarction, a heart attack to occur. So they are still clinically relevant and would benefit from medical management. So in going forward again, we can categorize a stroke based on etiology, based on severity, and the final one is related to specific vascular territory. These would be examples of different regions in the brain where an artery can be compromised, and by that artery being compromised, that affiliate region of the brain will also be affected. And depending on where you are in the brain, you'll have different signs and symptoms. Today we're going to be talking about the anterior cerebral artery and the middle cerebral artery. Now, when looking lower down, such as the posterior cerebral artery syndrome and lacunar syndromes, well, that's going to be coming up next week. For now, we're going to be looking at two different categories of vascular territory that can be involved: anterior and middle cerebral artery. So in looking at the anterior cerebral artery, sometimes presenting as an anterior cerebral artery syndrome, and again, a syndrome is where you have a collection of signs and symptoms that make it up. And so if we're looking at a cerebrovascular accident, a CVA, which is another term for a stroke, occurring in the anterior cerebral artery, it's a relatively less common form of presentation. But there are some common characteristics that make up how someone would present if they had this particular stroke. First off, you're going to have contralateral hemiparesis, mainly in the lower extremity. So by that, what we're talking about is you're going to have an impaired motor function that's going to be on the opposite side. So the individual, if they had a stroke in the anterior cerebral artery on the right, would present with left leg motor function impairment, difficulty walking, difficulty lifting the leg to try to do stairs, and performance of functional tasks, for example. They're also going to have contralateral hemisensory loss, again, mainly in the lower extremity, where they have an impaired sensation. So not only are they going to have difficulty in performing a movement, they'll also have difficulty in giving feedback. So if you were to test their sensation, say with a cotton ball, or if you were looking to test their ability to identify the sensation of a sharp versus a dull sensation, it would be impaired in the left lower extremity if they had a right anterior cerebral arterial accident. With that in mind, let's come around to a couple questions. Why is it that we have sensation and motor that's impaired? Why is it, in this case, it's mainly in the lower extremity? And why is it that it's on the opposite side? We're going to break that down. So first off, the anterior cerebral artery and its supply is generally in the medial frontal and parietal lobes. So to get a sense, we're going to be here. Now, try to appreciate from this slide that we're actually looking at the interior or inside part of the brain. That's the medial section. So if you were to look at the brain and you were seeing that there's two major hemispheres, picture how we're on the inside part of those hemispheres, more so towards the middle, and we're curving down and inward to where those two sides of the brain come together. And where it's going to affect this region here in the medial frontal lobe and the primary motor cortex, this is one of the reasons why we're going to have what's known as some paresis, or limited ability to perform motor tasks, muscular activity, movement. And where we're also going to be affecting the parietal lobe, in that region there, we have a primary sensory cortex as well. And that's where we're going to have our sensation that's going to be most apt to be picked up from the periphery, from the limb. And if we now have it compromised at this particular cortex, our ability to appreciate sensation, vibration, sensation, temperature, pain will also be compromised. So we have the medial, frontal, and parietal lobes, and there's going to be both a sensation and motor component to both of these. So on the left, we're going to have a somatosensory or sensation-based regions of the brain, and on the right, we're going to have the primary motor areas of the brain. And this is demonstrating it for the right cerebral hemispheres. So if we're looking here at what is the sensation-based region, and we're talking about, again, the medial frontal and parietal lobe regions that are relevant, here in this somatosensory area of the right cerebral hemisphere, notice that it's mostly involving the toes, foot, leg, and hip. Now, this comes around to the term homunculus, where there's different regions of the brain that are representing different parts of the human body. And there's some that are going to be specific to particular regions, such as here, this medial section. And that is all lower extremity. So the lower extremity for sensation and the lower extremity for motor representation are going to be more likely affected, again, by an anterior cerebral artery stroke. So we've had a chance to discuss why sensation and motor impairment can happen, and why it mainly happens in the lower extremity. But why is it that it happens on the opposite side? So here we have the primary somatosensory cortex that receives sensory input from the opposite side of the body. And we're going to be looking at two different things. A pathway that is dedicated towards primarily the sensation of touch, and a pathway that is dedicated primarily to the sensation of pain. We're going to compare the posterior column medial lemnicus to the anterior lateral or spinal thalamic pathways. So first off, the posterior column pathway. This is going to be utilizing focus on sensation. So if we have a touch, a vibration, something that's in the lower body, and in this case, for example, the lower extremity, that sensation will travel up the nerve in question to the spinal cord, ascending up the spinal cord, and then as we go up this posterior part of the spinal cord, this posterior column, it's going to get to a point in time where in the medulla, or above the spinal cord proper, it will then shift to the opposite side before ascending up into the brain. We can contrast that with the anterior and lateral spinal thalamic pathways, where we have, again, a crossing that will occur. But instead of that crossing happening here above in the medulla, above the spinal cord, the second order neurons, i.e. where the crossing will occur, in this case will happen at the spinal cord before ascending up. So again, sensation will come up, and in this case, the sensation will be temperature, like cold or hot. Crude touch as well as pain will travel through and then stopping here within the spinal cord, and then there will be a second neuron that will allow for the transfer of information up and to the spine, all the way to the brain. On the previous slide, we discussed some of the pathways that are involved in sensation. And sensation can be touch, sensation can be pain, but we start out arguably in the periphery where the sensation is noted and where that particular sensation travels by nerve impulses up to the brain. Now we're going to discuss how the brain will generate nerve impulses and send those signals down through the spinal cord and out to the periphery to ensure that muscles will perform a particular task. Here on this slide, we're looking at motor axons that cross to the opposite side of the spinal cord. Case in point, the anterior corticospinal pathway. We have upper motor neurons, and these are nerves that are in the central nervous system that cross to the opposite side of the spinal cord at each spinal cord level before synapsing with the interneurons or lower motor neurons. So if you follow that pathway down, it continues on all the way down through to the spinal cord until it finds the particular level that it has to then cross over to synapse directly towards the muscle that it will innervate. We can contrast that with the lateral corticospinal pathway. Again, we have an upper motor neuron that will first begin here in the brain and will travel down through from the brain down to the midbrain, pons, medulla, and here is where it will cross. It won't continue on that particular same side. It will cross at the medulla and then go towards the opposite side before further descending. Now, the anterior and lateral corticospinal tracts are different in that the anterior corticospinal tract is involved in controlling proximal muscles, like those muscles that are present in the trunk. Contrast that with the lateral corticospinal tract. The lateral corticospinal tract controls movement of the limbs. Now that we've had a chance to better understand the anterior cerebral artery and how it might present if a stroke should occur in that region, let's now contrast that with the middle cerebral artery syndrome. The middle cerebral artery is the most common site for an occlusion to happen and can produce extensive neurological damage with significant cerebral edema. Some of the common characteristics of this presentation include contralateral hemiparesis, or again, lack of motor control, a contralateral sensory loss, but in this case of the face, the upper extremity, and the lower extremity, with the face and the upper extremity more involved than the lower extremity. So that comes around and raises the question of, we have a contralateral motor and sensory loss as per before, but why is the face and the upper extremity more involved than the lower extremity in this case? So if we look at the middle cerebral artery and where it supplies towards the brain, it supplies the entire lateral aspect of the frontal, temporal, and parietal lobes. So it covers a fairly large area. There's also some subcortical structures that it will also cover. These are structures that are within the brain, not to the surface. So if we're involving the frontal lobe, that's going to involve the primary motor cortex. And that's going to affect the motor cortex in some ways similar to the anterior cerebral artery, just a different part of it. If it affects the primary motor cortex, we will have some paresis, where there is going to be motor function or muscle control will be limited. The parietal lobe, which is more here in the posterior, is again involved in sensory, and as a result, if the middle cerebral artery is compromised, that can result in impaired sensation. So again, we're coming around to the homunculus and appreciating that with the middle cerebral artery, it affects the lateral, frontal, temporal, and parietal lobes. So in contrast to the anterior cerebral artery, we're no longer going to be in, per se, this region that's compromised, but we're now out to this region. And while there can be some progression to include the lower extremity, even up here to the hip, we're more likely to see the upper as well as face affected to a greater extent in both the sensory and motor presentations that we see in the brain. We're going to see a greater amount of facial and upper extremity compromise. So we have both a motor and sensory homunculus map that is more involved towards the upper extremity and the face. Keep in mind that the middle cerebral artery does go across a significant amount of territory. And although in starting here we have discussed how it can influence the face, arm, and some of the leg for both motor as well as sensory by influencing these regions here, these regions are not alone. There is a sensory association cortex that is nearby the sensory cortex, and it's involved in our perceptual awareness. Individuals who have a middle cerebral artery stroke may present with a unilateral neglect, where although they have the visual capability to see what's going on one side of their body, they're not perceptually aware of its presence. They're more likely to bang into furniture and unable to acknowledge people or structures, objects that are on that particular side. So in this case, we're more likely to see it for individuals that have a right lesion or on the right side of the brain involving the medial cerebral artery. If we're going down here towards the more temporal area, we're looking at what's deemed Wernicke's area. Now, Wernicke's area is going to be involved in aspects of communication. And there's a phenomenon known as fluent aphasia, which we're going to be discussing in a few slides. This is typically found in a left lesion of the middle cerebral artery. Going a little bit more towards the anterior, we have a region that's also involved in aphasia or communication aspects, and this is known as Broca's area. And Broca's area is what would be deemed as a non-fluent aphasia. This is also seen typically in a left-sided lesion of the middle cerebral artery. If we go a little bit more superior, we could see that there are some regions that are involved in the eye fields, and if compromised, this will limit our ability to conjugate our gaze or bring it together in terms of some of the visual field aspects. And we also have some optic radiation in the internal capsule, which would result in a particular presentation known as homonymous hemianopia. We're going to be talking about that in a few other slides as well. But let's appreciate that there's a multitude of different aspects beyond just a sensation and motor restriction affiliated with this particular presentation of stroke. So to give a little bit more detail related to the middle cerebral artery, we're going to go over some selected impairments. Fluent aphasia, also known as Wernicke's, non-fluent aphasia, known as Broca's, homonymous hemianopia, and also touching a little bit on spasticity. Aphasia. Now, aphasia is an impairment of language, and it tends to affect our comprehension or our ability to produce speech. And it's almost always affiliated with an injury to the brain and frequently associated with stroke. We're going to contrast two different types of aphasia. There's a receptive speech impairment known as Wernicke's or fluent aphasia. And that's where we have damage to the posterior to central fissure, known as Wernicke's area, usually on the left side. And it's impaired auditory comprehension and fluent speech with normal rate and melody. What we mean by that is an individual will be able to speak at a rate that would be deemed as normal, but their ability to generate based on auditory comprehension will be broken. They will be able to generate a series of words that together may not make sense in the context of the communication. They'll fluctuate from different terms, where they'll talk about what's going on to the shoe, on which way you have to grab, and I talked to her and she was fine by what she needed me to see. And as I was rambling on there, you could understand that I was forming the words in a speech pattern that made sense, but what those words were linking together, it didn't make sense. Now we can contrast that with Broca's aphasia. This is a motor speech impairment, and it's a non-fluent aphasia, where there's this damage to the anterior central fissure on the left side, and the result is a limited vocabulary and slow, hesitant speech. So an individual that presents with Broca's aphasia would have problems with thoughts into speech. They would have awareness of what's going on in terms of interactions, and what they could form in communication would make sense, but their ability to generate that is non-fluent. It is broken. Homonymous hemianopia. This is a visual representation of what you might see if you had this clinical condition, where your visual field would be cut in half. You would have an awareness of what's going on visually on one side, and the other side would be completely dark. It is not because you have an eye issue. It's because you have a connection to the eye issue. So let's talk about that. Homonymous hemianopia. So we're looking at a better sense of why this partial blindness in half of your visual field will occur. Let's look at a visual representation of this. So here we have the eyes that will take in your visual field. You can see that over here on the left side, it's going to be primarily the blue. On the right, primarily the yellow. And there will be overlap here in the green. Everything that comes in from the visual field will be taken in by the eyes, and relevant information will be transmitted along the optic nerve, which will in turn, if you follow the pathway of the optic nerve, you'll notice that it does split. So right here at this optic chiasma, this is where we're going to have the two halves kind of desiccate or split. One will continue on the same side of the brain, and the other one will shift to the opposite side of the brain. As it travels further posteriorly, it's going to eventually synapse with the thalamus in the thalamic lateral geniculate, and then finally leading into the posterior, where there's going to be this optic radiation and area that's going to be dedicated to taking the neurologic information into the brain and making some sense as to what's going on. Now, let's say that we have here on our left side a lesion. This left parietal lobe will place some pressure on the left optic nerve. That's going to happen right there where we have our red line. Now, if that should occur, that's going to have an impact because things cross on both the left and the right eye. Which comes around to the question, will you see the phone or the camera if we place it in a particular field? You'll see the phone, not the camera. Let's give a bit of an explanation as to why. This homonymous hemianopia is where, again, hemianopia is a partial blindness in half your visual field, and homonymous affects the same side of each eye. In this case, damage to the left side of the brain can cause loss of the right field of vision. So if we follow our pathway going up here, this blue line here that's affected by our lesion comes out and innervates this outer or lateral portion of the eye. Well, this portion of the eye is responsible, more so if you follow the angle, for this area here, where signals that come from this angle will come in and strike here. And so if it's not picking up in this area well, you're not going to get anything visually from this corner or where the camera is. Contrast that with the yellow branch that goes to the right. That's going to be more on the medial or inside of the eye. And again, this area here is going to be more so responsible for this region of visual input. Now, because this lesion is unilateral, you're still going to have this section and this section that will be able to give you information on the opposite side. Here's the medial side of an eye. It's going to be able to see the phone here on the left. Here's the lateral side of the other eye, but it will still give you information of the phone on the left side. So this right homonymous hemianopia highlights that you have a partial blindness in half the visual field, in this case on your right, that is going to be the same for each eye. One of another impairment that we want to talk about related to middle cerebral artery, but isn't limited just to middle cerebral artery, is spasticity. Now, actually, this is going to come up in discussion in our next lecture, but it's something that we want to give a little bit of thought to now. So a couple of questions that we're going to address next time we talk. First off, if the major physical impairment of a stroke is spasticity, how does this happen? And what is it? Meaning, what is spasticity? Is it a part of a pattern of recovery after a stroke? give some thought to those 2 points leading into next week. In coming to the tail end of this lecture, where we've been discussing stroke, we're going to add in a little bit of the concepts related to rehabilitation. Let's appreciate that an individual who has suffered a stroke will have various functional limitations or capabilities based on, again, etiology, severity, and what anatomic location the stroke has occurred in. So how do we measure some of that? Well, there are tools that have been implemented, and one of them is the Functional Independence Measure, FIM. It's a scale that's used in rehab settings, and it measures functional skills such as dressing, bathing, and eating. And you rate each functional skill from a scale of 1 to 7. If you're completely independent in a task, that would be a 7. If you need supervision, it's a 5. Moderate assist from someone else, 3. And finally, if you need total assistance from someone else, that would be 1. So a maximum score is 126 across these various tasks. And it makes sense that the lower the score, based on what we discussed, is indicative of a lower functional ability. So when looking at a scenario that utilizes the FIM score, let's look at an inpatient rehab setting. We have a patient who has been admitted to the rehabilitation floor of a hospital, and the length of stay that they are there for rehabilitation is going to be, say, approximately 38 days. That would be on average for people who have been admitted to this particular floor. Initially, on admission there, testing was completed in terms of their functional capability, and they scored a 77. On discharge, they scored a 99, which means the total change, 22. And again, for the scale, the higher the number, the better off you are doing functionally. Now, for a majority of people that have been admitted to a rehabilitation floor, we can say that they are going to be able to become discharged to the community. Now, that may involve the need of extra support, extra ambulatory equipment, like use of a cane or a walker, or being in an environment that will allow them to minimize the amount of stairs or so forth, but to some extent they'll be able to be safely discharged. There will be a minority of patients that, in comparison of the goals that were developed based on the initial admission FIM score, we're going to find some that can meet those goals partially, but may require a little bit more help, so a referral to other ongoing rehabilitation services in the community, or a transfer so that the individual may not be able to go back to their home, but may require to go to long-term care. And there's another minority of patients where their clinical goals were not met. The development of clinical goals are based around appropriate outcome measures. An outcome measure, such as the FIM score, will give some context in terms of what the expectations are. If you're at a lower score in the beginning, you may have a limited ceiling. If you have a higher score in the beginning, your functional capabilities upon discharge will be even greater. The clinician has to make an appropriate goal to address this, and it's going to vary from patient to patient based on the factors we've discussed in this lecture. So as a summary of some of the points that we've highlighted in the lecture, let's keep in mind that there are 2 main pathological mechanisms, ischemia and hemorrhage. The presentation in terms of severity of impairment can be variable, and we might need to have certain scales, such as the FIM, as an outcome measure to give us a sense of what the patient's current presentation is like and our expectation of how far they can go. And the impairments that a patient presents with are related to cortical mapping and its blood supply. So you can compare the anterior to the middle cerebral artery and see the differences in what sections of motor and sensory compromise, as an example, how they differ in terms of cortical mapping and blood supply being affected.